My name's Rich Gula. I specialize in non-invasive cardiology and in imaging, cardiac imaging, particularly echocardiography, nuclear medicine, CT, Holter monitoring, EKGs, etc. So I'm one of the diagnostic cardiologists, and my job is to take the bud of a flower, for example, and figure out what that flower is going to turn into when it finally blossoms, okay? So once I do that, I listen to what you have to say, I examine you as a patient, and I try and make the determination, and if you need additional work, I send you to the appropriate person. For example, if you have a coronary blockage, I would refer you to an interventional cardiologist. If you have atrial fibrillation, an irregular heart rhythm that I can't control myself, then I send you to an electrophysiologist, somebody who may do an ablation procedure where they apply a light shot, a light hot probe or cold probe in the heart at the location where the irregular rhythm is. So we function that way. I send patients for surgery, valve surgery, bypass surgery, different things like that. So that's my job, is to be the diagnostic guy. And you're all welcome to come and visit me. So you're going to learn my favorite color based on the slides. You'll probably figure out where I'm taking my son for his college graduation. And hopefully you'll learn something about the risk factors of coronary artery disease. So being a Catholic hospital, I figured my topic should be based around the 10 Commandments. And so my topic is called Thou Shalt Not. And these are the things that you need to do to keep your heart healthy and happy. These are the 10 risk factors. So you can see when I got all the way to 10, I didn't have a 10, so I had to put unknown, since there's 10 commandments. So let's talk about hypertension. The ideal blood pressure is 135 over 85, not 140 over 90, okay? Not 160 over 90. It's 135 over 85. And those are recommendations that came through a long process of study and research. These guidelines were changed about 2 years ago. They're becoming more and more restrictive because we're finding clear evidence that the better your blood pressure is, the less likely you are to have a stroke or a heart attack. Most high blood pressure is essential. That means as we get older, our blood pressure has a tendency to rise. We don't know, in most circumstances, why it rises, other than that's the nature of the human being. About 5% of high blood pressure has secondary causes. For example, if you have an artery in the kidney that's getting blocked down, that will drive your blood pressure up. And as I say there, it's more common with age. Ways to treat your blood pressure: reduce salt intake. My wife is kind of snickering because I like to put salt on my food, and she always tells me, don't put the salt on your food. Decrease your alcohol intake. Decrease your stress if possible. Control your anger. Now this is really important. To control blood pressure, it's important that you exercise. When you exercise, your blood pressure will rise, but that's normal. That's a normal physiologic response. But regular exercise will make your baseline blood pressure lower, and that's critically important. And then I put on there sleep. We now know that if you sleep poorly, if you have sleep apnea and you don't control it, if you have any kind of a sleep disorder where you don't go into your normal 4 stages of sleep plus REM sleep, it's going to drive your blood pressure up. So sleep is important. That is not to say that you can't use sleeping aids. If you sleep poorly, talk to your doctor, have a potential sleep study done, and find out why you're sleeping so poorly. If you have sleep apnea, use the CPAP unit. Use it. It will make you feel better, and it will control your blood pressure. And if you do have high blood pressure and you have seen a physician, take your medicine. It will help you in the long run. High blood pressure is insidious. It will gang up on you as you get older. So the longer you have high blood pressure and the more poorly controlled it is, The stiffer your blood vessels will be, the more likely you will be to have a heart attack, a stroke, kidney failure, lose your legs, different sequelae from high blood pressure. Now, diabetes is a major risk factor for coronary artery disease, and unfortunately, diabetics are at a higher risk for coronary artery disease because the sugar irritates the blood vessel. 18 million Americans have diabetes, which is about 6% of our population. There are 800,000 new cases of diabetes annually at the cost of $1 billion in health care. It's the #1 cause of mortality and early disability in the United States. Diabetes leads to heart attack, stroke, blindness, kidney disease, kidney failure, potentially hemodialysis, amputation, and peripheral vascular disease. And these complications can be prevented. Good diabetic management and close follow-up by a physician will help you to prevent these side effects. There's basically 2 forms of diabetes. Type 1 diabetes, which generally affect younger people, children, whether obese or non-obese, but more commonly non-obese children. And it basically is a result of the non-secretion of insulin. The most common form of diabetes and the most common form amongst adults is type 2. This is 90% of all diabetes. There may be some need for insulin medication, but this is our big one. And the symptoms of this is the symptoms are usually insidious as well. They usually start with fatigue, weakness, blurred vision, and dizziness. Therapy can be delayed, and diabetes can be controlled by early exercise programs and diet control. This is well known. This is a study that came out about 5 years ago. People who have new onset diabetes can probably keep themselves off of medication if they vigorously exercise. And we'll get to the exercise component. So why coronary artery disease? Well, diabetes causes your cholesterol to rise. It causes the platelets in your blood to become more sticky than usual. It causes the inner lining of the blood vessel to become irritated. And your whole coagulation system, the clotting mechanism, is fired up. It wants to clot. It wants to create problems. So how do we take care of diabetes? Well, obviously, a diabetic diet is critically important. Reduce alcohol intake if you regularly drink alcohol. That doesn't mean an occasional glass of wine is bad, but you know that alcohol is made with sugar, so that's going to push things up. Exercise is critically important. Take your medication. Regular checking of your hemoglobin A1C level is important. That gives the doctor and you an idea of how poorly controlled your sugar is over a period of time. Not today or not yesterday, but more like over the last 3 months. So it's a great marker that we use to find out if your sugar really is controlled or not. Oh, and make sure that you not only see your doctor, but ask your doctor to have a nutritional expert see and evaluate you. We know a lot about nutrition, but we're not nutritional experts. And a diabetic nutritionalist is really very important. They will help you to know what's good, what's not good, what to avoid, what's okay to take. Very important. Well, let's talk about lipids, cholesterol. This affects 1 million Americans as a whole. 12 million adults qualify for therapy. Lowering the LDL cholesterol will reduce the progression of coronary artery disease and coronary mortality. A 10% decrease in your LDL cholesterol will actually decrease morbidity and mortality by 2%. That doesn't sound like much, but 2% is actually a significant reduction in mortality and morbidity. So if you have an LDL cholesterol of 130 and you can bring it down to 110 by either diet or medication, you decrease your morbidity and mortality by 2%. And every 10% that you can reduce it below that, you bring it down 2 more %. So you can really bring down the secondary side effects of cholesterol by getting it down and increase your longevity. Studies over the past 5 to 10 years have shown that not only does reducing LDL cholesterol reduce your morbidity, but if we can get your cholesterol, your LDL cholesterol, below 70, it reduces the size of the plaque inside the blood vessel. So we actually can regress the amount of blockage in the blood vessel if the blockage is caused by cholesterol. So there's lots of different forms of cholesterol, and patients come to my office all the time and they tell me their cholesterol is 240. Well, one cholesterol measurement, the total cholesterol, really is meaningless. To me, it's of no value. When you have a cholesterol profile, nowadays, there's usually about 5 components. And if we really need to fractionate your cholesterol down, we can get about 27 components out of it. And some patients need this. Some patients, we have to look at those really small particles, because when we look at the gross numbers, the five that we do routinely, they may look okay, but a person still has coronary blockages or stroke or heart attack. And let me just say that cholesterol isn't the only cause of heart attack, and also all people who have high cholesterol don't necessarily have coronary artery disease. I have read studies that say only 30 to 50% of people who have heart attacks have elevated cholesterol. So there's lots of different factors involved. So cholesterol is not the only thing, but it's really important. Cholesterol is produced in the body, and also we eat cholesterol. So in trying to control our cholesterol, we have to do both. We have to decrease the amount of fats and cholesterols that we're eating, and we have to reduce the cholesterol production, and that's why we use the cholesterol medications. People can't usually control their cholesterol just by diet. Usually it's a combination of the both. Sometimes it does go to either end of the spectrum, where it's just diet or just production. So cholesterol is needed in the body to make hormones, basically. We need cholesterol. So we do need to eat a little cholesterol, and our body does need to produce a little cholesterol. In fact, there are studies out that show if your cholesterol is too low, that's a bad sign. You can be in trouble. It's a sign of how your body is functioning if you're not on any cholesterol-lowering medicine and you're not dieting to keep your cholesterol under control, and you come in with super low cholesterol levels. That's a bad sign. So fortunately, we rarely see that, but so cholesterol is important. It's important in the body. Does this thing work? There we go. So here's the answer to your question. The LDL, the bad cholesterol, creates foam cells, and these foam cells get under the inner lining of the blood vessel, and they start to build up and cause plaque and hardening of the arteries. Now the good guy, the good cholesterol, is the HDL2. You want that as high as possible. So you want the LDL down, and you want the HDL2 up. There's actually 3 HDL molecules. You can have high HDL, but if it's the wrong high HDL, it's not doing any benefit to you. The HDL2 kind of carries those foam cells back to the liver and cleans the blood and gets rid of them. We excrete it. So HDL is very high, usually in premenopausal women, higher than in men. And that's why one of the reasons premenopausal women have a low incidence of coronary disease. That's premenopausal women. So here are our goals for cholesterol. Total cholesterol, which I don't like to use as a test, we want to keep that under 200. So if you only have one test and it's a cholesterol, you kind of want to get it under 200. The LDL, the bad guy, if you have no coronary disease, you want to get it under 130. If you have coronary disease, you have got to have it under 100. And the new guidelines are to get it under 70. If you get it under 70, it really helps to prevent progression of coronary disease that is caused by cholesterol. There's other causes of coronary disease, but the one caused by cholesterol can be actually reduced. The HDL, the good guy, you want it higher than 40. The higher, the better. If your doctor can fractionate it down for you, you're looking for the HDL2. Triglycerides turn around and become bad cholesterol. Triglyceride is a 3-sugar fat molecule, and it's highly related to sugar and diabetes. So if you had a piece of blueberry pie last night and you go get your blood test today, there's a high likelihood your triglycerides are going to be up. And that's why fasting samples are important when you're going to check these. And of course, the longer you fast, especially avoid eating sugars and fats, the more likely you'll find your true level. But if we're eating sugars and fats all the time, our triglycerides are going to be up, and they circulate through the body, and eventually they turn into a bad guy. So the headline from Cardiovascular News Digest on February 2nd of this month show, studies suggest current thresholds of what physicians consider normal LDL levels may be too high. And this is what we were just talking about. So now the recommendation is that if you have a LDL cholesterol greater than 100, you should be put on a statin to prevent coronary disease in the future. So the goals of cholesterol therapy: diet, avoid saturated fats and trans fats in the diet, avoid high alcohol intake, exercise regularly, and take your medications. These medications may be statins, niacin, which is a B vitamin, fish oil. Over-the-counter fish oil is almost worthless. Take it, it won't hurt, but the fish oil you want to take are prescribed. They have eicosapentaenoic acid and another special acid in them. The ones over the counter have very little or no eicosapentaenoic acid. I tell my patients to keep taking it because we don't really know what a little level like that is going to do. It certainly isn't harmful, and it may be helpful, so take it. And you also need to take 4 grams. So taking 1 capsule of fish oil is really not going to do anything for you. You need to take up to 4 grams a day. And in terms of the statins, people come into my office all the time. They're scared to death about statins. They're going to have liver failure. You know, everything bad in the world is going to happen. Well, statins rarely cause trouble. 10 years ago, there was a lot of information on the news about the combination of a statin and another medication, and people did die from it, but it wasn't from the statin. It was from the combination of those medications, and so they took it off the market. Statins are tremendously beneficial, and they work on more than your cholesterol. They're beneficial for other things, and we'll get to that part. So now we can talk about tobacco. Is anybody smoking here? Is anybody brave enough to admit that they smoke? I won't look. So this is a no-brainer. If you smoke, stop. If you can't stop smoking, ask your doctor for help. Next line was meant to be funny. If you're exposed to smokers, I guess you have 2 options. Throw them out, or ask them kindly to stop. Secondhand smoke is a killer. We know that now. We didn't know that. We didn't think that that was necessarily a risk factor. But secondhand smoke is harmful. And it is not okay to smoke when you drink. Of course, if you drink all the time, you smoke all the time. But if you go to the bar, you know, I hear lots of people, they go and they have a drink, and when they have a drink, they light up a cigarette. That's not okay. It's not okay. It's all additive. And I want everybody to pay attention to this last line here. If you have smoked for 1 year, ever in your life, you have caused some amount of permanent lung damage. And sometimes, very commonly, we see it all the time, people will come in 20, 30, 40. I had a lady who came in 50 years after stop smoking, and she had bad lung disease. And it gets to a point, people tolerate what's going on in their lungs up to a point, and then there's something that happens in their life, whether it's age, whether they get infection or pneumonia or something like that, and that tips the scale. and now they start wheezing, they're coughing, they're bringing up phlegm. This is all from the tobacco you smoked 20 years ago. Don't be fooled. 1 year of tobacco equals a potential future of lung problems. Okay? So if you smoke, stop. Gender. Coronary disease seems to affect the male gender at a younger age. We have studies showing coronary blockages in young men age 18 to 20. They did studies on soldiers who were killed in war, young people. They found them to have severe coronary disease. The famous Russian skater died of a massive heart attack about 10 years ago. I think his name was Petrovic. No, Petrovic's my family. I get you guys mixed up all the time. Popov or something like that. He was 24 years old, a world champion. He and his girlfriend were the team skaters, you know, and he just died on the ice one day. 24 years old. Tremendous athlete. Why would you expect that to happen? In him, it was genetic and external risk factors. But the point is that coronary disease starts very young in males, and then women catch up with their coronary disease about 5 years after menopause, and then their coronary disease accelerates faster than men. So this is what all this new stuff is about women and coronary disease. You've been hearing on the news. Women have a different set of symptoms of coronary disease than men. And if you want to know more about that, there's a talk I'm giving. I think it's called Go Red, and it's a talk on women's coronary disease. I think it's February 24th, and it's at the Hilton Garden Inn. And that talk is going to be just focusing basically on women's coronary health. So if you have symptoms, don't blow them off. And if you have atypical symptoms and you even think that it might be your coronaries or your heart, don't blow them off. Come and see Joe or I. Because you need to get started. You need to make sure that your coronaries are okay. And if they're not okay, we need to get them taken care of. We need to look at your risk factors. We need to help you get those things adjusted. Obesity. We always suspected obesity was a risk factor, but now we have proof that it's a risk factor. The ideal body weight is your body mass index, not your actual weight. You have to have a ratio of your size in terms of your weight and your height to determine if you're obese or not. And the ideal body mass index is 25 to about 30. And there is a formula to use and all kinds of tables that we have available that we can figure out for you whether your body mass index is good or not. Obesity will cost more than $1 billion a year in health care. The government is really concerned about this because it's going to bankrupt them faster than Obama's stimulus package. So we have a big problem here in the United States with obesity. It's massive. Cities, people tend to be thinner because they walk and they get around. The youth, boy, we got to get them off of the chairs, out from behind the computers. You know, the average child uses a computer or a game 6 hours a day. That's the average. Anyway, and regular diets, you know, all these diets you hear about, they're good, but they only work for a short time. Most cardiologists recommend decreasing your caloric intake and exercise. And if you can do that on a regular basis, you'll get your weight under control and it's heart healthy. We're not opposed to diets, it's just that most people can't maintain diets for a long time. What causes diabetes? Well, genetics from parents to children. Constitutional factors. This is kind of interesting. Undernutrition in the first 2 months of pregnancy. So if a woman is pregnant in her first 2 trimesters of pregnancy, she's trying to stay ultra thin for, you know, whatever reason. That leads to increased obesity in the child, in the offspring. Infants of diabetic mothers, this is to be expected. If the mother's a diabetic and she's got a lot of sugar floating around, there's a higher chance that you're going to have a large birth weight baby. And then intrauterine exposure to the diabetic condition. So if the amniotic fluid is sugar-filled because of poor diabetic control, then there's, again, a higher risk for obese children. Here's the environmental factors. Children lack physical activity. They like computer games, and so our children are getting fatter and fatter. The food we eat is important. We have a tendency to eat low-energy foods, high-fat foods, not enough vegetables, fast foods, and we lack control in what we eat. Boy, it tastes so good, I'll just have a little bit more. My mother-in-law is a pretty darn good cook. And I have a real problem in my household because I love the food she cooks, and I just want to keep eating it. And you know, you have to say, okay, this is all I'm going to have, and then you have to walk away from it. You just can't keep eating. And physical activity and exercise, we're going to come to that, and there might be some viral origins of obesity. So we know genetics affects gender, diabetes, obesity, and cholesterol. It may affect hypertension and inflammation in the blood vessel, but there's a whole lot about genetics that we just don't know about. We do know that twins in their young age have a direct correlation between them for coronary disease. So if one has coronary disease at a young age, the other one probably will have coronary disease. As they grow older, though, the environmental factors seem to take over and the coronary disease becomes less of an impact. The other thing that's interesting is genetic makeup influences how our bodies handle our risk factors. So you can have people who smoke, they eat terribly, you know, they have every risk factor, but they have no coronary disease. And then you can have people who have taken care of all their risk factors, everything looks good, they've really trimmed everything down, and yet they have coronary disease. So these are where the genetics come in. We don't know how to control that yet, but we do have studies now to show that genetics has a direct relation to coronary disease. So what did your parents die from? If your parents died from coronary disease, your ears should perk up at this point, and you should do everything you can to control your risk factors. Well, this is probably the most important part of the talk, because this is something that you really can control more than anything else, is how much exercise you do on a regular basis. We need to make sure that people are exercising 3 times a week at the very minimum, but better 5 times a week, and they need to exercise 30 minutes at an exercise time frame, and if possible, get your heart rate up to 130 or higher. You want to start slow and build up, and you want a cool down period at the end. Aerobic exercise, the kind of exercise you should be doing, includes walking, biking, jogging, dancing, swimming, anything that's going to strengthen the heart muscle. These are endurance activities. Weightlifting and things like that are good, but they're not the best part. And you can do weightlifting, but about 2 times a week. The most important thing is all the other physical activity. Balance exercises are important. So you can be out there doing all this stuff, but you should also do balance exercises. Practice standing on a foot, anything that has to do with balance. If you're chronically ill, if you have emphysema, it's important that you do something. Get off the couch and move around, even if you're carrying oxygen. Move. It's not good to just be sitting. Inflammation. Inflammation is irritation of the blood vessel, is what I'm talking about in this case. The inner lining of the blood vessel. It can be caused from diabetes, high cholesterol, infection, noxious stimuli, and from unknown causes. We can measure this with a test called high-sensitive C-reactive protein, and that we now know is an additional marker for coronary disease. In and of itself probably doesn't mean much, but it's just another risk factor. It tells us that your blood vessels are not happy. And here's where I was talking about statins. So not only do statins help your cholesterol, but it helps to cool the inflammation. And if you can cool the inflammation, you can decrease the irritation and decrease your risk of heart disease. And then the things that we don't know yet, there's a lot of research going on looking for ways to help people reduce their risk factors for coronary disease. There isn't any cardiologist who wants you to have to come to our office. It's a trophy for us if we get you better and you don't have to come back, or if we can prevent you from having to come in. So public information is really important. Whatever you can learn and you can control on your own is really, really important. So why control the risk factors for coronary disease? Extend survival. The longer you live, hopefully, the more fun you have in life. You can improve your quality of life. We can reduce our need for stents and bypass surgery. And we can reduce our risk for future heart attacks. So in summary, you want to control the blood pressure, control your diabetes, control cholesterol, stop smoking, lose weight, regular exercise, a baby aspirin a day. Studies are showing that that's beneficial. Flu shot, you should all take a flu shot. Studies now show that people who get the flu, who have coronary disease, have an increased mortality. So you need to get the flu shot. Take your medicine as your doctor prescribes. He's really doing that in your best interest. Even though it seems to be expensive, there is a method to our madness. So I want to thank you all for coming and seeing all of us and staying for my talk.
Sometimes you can do all the right things.
Diet and exercise and stress management, trying to keep a good balance in your life. But the genetics thing is something that you have to deal with. And in my case, we think that that's probably the biggest factor in bringing on my heart disease. The same Irish grandmother that I got my nice skin from, I also got her heart disease and her stubbornness. So in the year 2000, I had just had an EKG because I'd been having some episodes of chest pain, and we found out there was some abnormality. From April, when everything showed up normally on the EKG, to September, there'd been some changes. And I had the one minor treadmill test or something to that effect, and then was scheduled the following week for a more intensive study. And Saturday morning woke up with chest pain, and that was one of the symptoms that was really hard for me to interpret, because I assumed that you get chest pain when you have heart disease when you're putting a strain on your heart. You know, you're out there shoveling the snow, we all know those stories, and you fall over. But I would wake up in the morning with chest pain, but I wouldn't have chest pain when I was doing activity. Well, I woke up Saturday morning with chest pain and knew that I had some abnormality in my EKG and said, you know what, I think I better go to the ER. And sure enough, went in for a cardiac catheterization that morning, and they discovered that I had about a 90% blockage in what's called the widowmaker vessel, or the vessel that's the most involved with sudden death. So I had a stent put in September of 2000. Went on some medications and continued with my, low-fat diet and all those behaviors that they recommend. And everything seemed to be going along fine until 2000. I had chest pain, and it came and went over a period of about a week. And finally I decided, and I was working at a clinic at that time and had them do an EKG, and I left the clinic in an ambulance and had 3 stents put in. Now, mind you, I was doing all of these things that I thought I should do. And it made it more difficult for me to act on my symptoms because I was telling myself, I'm doing all these right things. But again, the genetics plays a big role, as well as inflammation. And I discovered that as I'm developing more and more arthritic joints as I get older, that's a factor in my heart condition also. So I had 3 stents put in May 14th of 2007. And 2 weeks later, I was out hiking by myself in the woods and, carrying on, having a happy life. So in September, I got a visit from one of my kids and the grandkids. And I was packing around a little baby girl on my hip for a week. And the day that they left, I had some pain on the left side of my chest. I assumed that I had pulled a muscle, stretched the tissue between the ribs a little bit from hefting that baby around a lot. Worked all day with chest pain, seeing patients. Went to bed that night with chest pain, and it kept getting worse during the night. And so I immediately went in to have it checked out that morning. And I had another heart cath and was told that all 3 of the stents had occluded. Most likely because of my hyperinflammatory response. The presence of 3 stents in my heart was probably more than my body could handle. And I have to tell you, though, that when the cardiologist came to me after I was fully alert and said, well, Erin, I have to tell you, I'm sorry to say, but you're going to have open heart surgery. And I knew this cardiologist pretty well, and he knew me pretty well, and we both liked to joke a lot. And I said, oh, you're joking, right, Bill? and he wasn't. So a few days later, I was here at St. Pat's Hospital and was checking in for my surgery, and I mentioned to the wonderful nurse, Sharon Welch, in the Heart Institute. I said, Sharon, I've been having this chest pain now for 4 days straight, because I'd had the heart cath on Friday. This was Monday morning. And she said, oh, really? She picked up that telephone. I wasn't scheduled for my surgery until Thursday. And they were going to get all the paperwork and so forth done. She picked up the telephone and got a hold of Dr. Maxwell. They whipped me right into the cardiac unit, and the following morning I had open heart surgery with the triple bypass. And I did experience a very minor heart attack before that. That's what my chest pain was telling me. Things aren't right here. And I think the message that I would want to deliver and emphasize is listen to your body. Pain is communicating something to us. And it's not smart, it's not prudent, it's not wise to ignore that. And if you're like me, you'll rationalize, well, it can't be this because I'm so good about doing all these things. So it must be this and it'll go away. But if it doesn't go away, have it checked out. And we're in a community that offers some of the best resources for cardiac care in the world. And you'll get kind attention, and you'll get wonderful care, and you might find out, well, yeah, it is a pulled muscle, or it's an indigestion issue, whatever, and then you'll get peace of mind. One of the things that are mysterious about women is that our chest pain isn't like the chest pain that they describe for men. My chest pain, which is all I can speak of, was right on the left side of my chest, just to the left of my sternum, and it was more of an aching, constant pain, kind of a squeezing type pain, nothing extreme. I mean, I didn't break out in a cold, clammy sweat. I wasn't short of breath. I will say that I did have fatigue for a number of months before my very first episode in 2000. But I attributed that to stress and just working hard. So I can't tell you, this is what your chest might feel like. But what I can say again and emphasize is that when you experience something that's not typical for you, you need to explore that. And this wasn't typical for me. And like I said, I always assumed, I'm not a cardiac nurse, I always assumed that chest pain would come with some kind of exertion. And you need to know that there are types of conditions with your heart function that produce pain at rest, during the nighttime, or just sitting at your desk. And you can't ignore those either. So after my open heart surgery, and I live alone, I went home for less than 24 hours, had severe chest pain at home, did break out in a cold, clammy sweat, and fortunately was having a visitor at that time who brought me back to the hospital. We did a few more tests, etc. And again, my tendency towards inflammation produced what's called pericarditis. The sac around my heart became inflamed and was painful, but it didn't kill me. It just nearly scared me to death again, but so that got treated too. And there are some bumps in the road in your recovery, but I'll tell you, one of the most comforting experiences I had was starting my cardiac rehab. I mentioned to you that after my stents were placed, I was out in the woods hiking by myself. Well, the thought of doing that after open heart surgery was frightening to me, thinking about being out in the woods alone, getting chest pain, falling over, all those things that you can scare yourself imagining. Going to cardiac rehab and having my exercise monitored, having nurses and other technicians there around while I was working my heart, helped my confidence and my peace of mind so much. So our cardiac rehab program here at St. Pat's is, again, like our other services here, state of the art. So, and I'll bet that there'd be some way that for those of you who don't go through open heart surgery or stent placement, that you could find a way to, well, the stress treadmills do that. They monitor your heart while they're exercising you. So I haven't been without problems. I've been in and out of the hospital a few times because I'm reporting my symptoms. It's still hard for the doctors to put a finger on just exactly, what produces my pain. But I know that I'm going to get good care here. And I know that if I do certain things like take my medications and watch my diet and have a balanced exercise program, that the quality of my life is going to be good. And that's something I'd like to speak to just for a second. that some of the other comments haven't touched upon it, and that is quality of life. Having heart disease isn't a bad thing. You know, we all have something that we have to live with, and you do. You live with your heart disease, and you carry on. I can say, and I'd say this to the patients I visit on the cardiac unit on 4 North, that sometimes these things can be a very good thing. And in my case, it helped me to reprioritize some things in my life. I did cut back on my work. I'm spending more time with my family. The whole pace of my life has slowed down. And I'm a happy person. I don't wake up in the morning thinking, gosh, I wonder if I'm going to have a heart attack today. I wake up thinking, gosh, I'm glad I woke up. And this is going to be a good day. And at nighttime, I lay there and I think, oh, this was a good day. I got to do this and this. And so I think I have a better quality of life as a result of having this experience. And I think it's possible for anyone to have a better quality of life because of having this experience. So it's not necessarily a bad thing. And you all should know that the care at this hospital is as good as it gets. We're really blessed in this community to have the Heart Institute and all of our providers here. I've nursed in 4 different states, countless hospitals, and this is the best place that I've ever been in. And I never worked here. I've just been a patient here. So.
You never mentioned your family history.
Oh, well, my grandmother, yeah. My mother passed away at 81, and she did have heart disease. She died from the effects of her smoking, mostly her lung disease was what caused her death. My father is still alive. He's 83 now. And he too has heart disease, but he's managing his life pretty well. I think I have the most serious heart disease in my family, but I've got another 100,000-mile warranty on me now with my bypass. And I'm 65 years old, so I think I got another 20 years to go. Thank you.